Welcome back. In session 3, we turn our focus to pain and harm reduction, a vital area for both patients and healthcare providers. Chronic pain remains one of the most common and debilitating conditions facing Canadians, and despite the array of treatments available, many patients continue to experience unmet needs, intolerable side effects, and diminished quality of life. At the same time, we are confronting a national opioid crisis, which has challenged our healthcare system to find safer, more sustainable approaches to pain and symptom management. For many, medical cannabis has emerged as a critical alternative, helping reduce opioid use, improve function, and restore quality of life. In this session, leading experts will explore the role of cannabinoids in harm reduction, from opioid substitution to recovery, and share insights from both clinical trials and real-world settings that are reshaping how we approach pain management. It is my pleasure to introduce Dr. Zach Walsh, a nationally recognized expert in cannabis and substance use research. Dr. Walsh is a professor of psychology at UBC and a clinical psychologist focused on cannabis and substance use. He has led Canada's first clinical trial on cannabis for PTSD and has published extensively on cannabis as a harm reduction strategy. He has also made appearances before the Canadian Senate and House of Commons to provide expert guidance on cannabis and mental health policy. As we face dual public health crises involving opioid use and alcohol-related harm, cannabis has emerged as a potential harm reduction tool. Yet clinical and policy communities are still catching up to the science. His work challenges outdated views and supports innovative care models for substance use. Please join me in welcoming Dr. Walsh.
All right, thank you so much for the kind introduction, and it's been just a terrific day so far, so I'm so glad to be here and to share a little bit of the work that we've been doing, following up on some really inspiring presentations, and hopefully I can tie some of this into some of the work that we've already discussed. All right, I don't need that slide because I've already seen it, but I do need the slide about my conflicts of interest. I know we often go through those pretty quickly, but I'm kind of proud of them. So I like to belabor them. I like to saute in my conflicts a little bit. So I have in the past received support from Tilray and Doja, and I'll talk a little bit about each of those studies. The Tilray study was the trial of cannabis for PTSD. It was done back pre-legalization during sort of what I think of as sort of the heyday of the dispensaries. And I'm working out of British Columbia on the unceded territory of the Silk Okanagan people who have lived there since time immemorial. And in BC, as some of you may know, there is a pretty active, and of course in Ontario as well, across the country, but in BC there's a very active cannabis culture. And so when I was doing my trial of cannabis for PTSD, people were saying, oh, you know, people would laugh and say, you must be chasing people away from the study, and you're giving away weed, wow, people must be lining up. But in fact, we ran the trial for, I think about 4 years with 6 participants. And it wasn't because we weren't trying. We very much wanted people to join the trial. But the reason I talk about this is because I think it points to some of the limitations around waiting for clinical trial evidence when it comes to cannabis. What we found, not surprisingly, is that people with PTSD in general who were curious about trying cannabis and who lived in British Columbia were trying cannabis. They had already tried it, and they were using it if it worked and not using it if it didn't. And so, you know, we weren't able to recruit people for our study, understandably, because if someone was already using cannabis, it would have been a trial of lesser cannabis than what they were probably already using, having determined what was effective for them. And if they weren't using cannabis, it's because they didn't want to, so they didn't want to be in a trial. So we were able to recruit some people, very grateful to them, and we published the study. But I think it points to this weakness that we have in the research where you know, people are skeptical and they say there's no evidence, wait for the clinical trials, there's no clinical trials. In the meantime, we have a green leafy plant that's been valued for its medical effects for millennia. and we're pretending we don't know anything about it and that we can't say anything for until we get clinical trials. So I'm very glad to be here and to be working with Avicanna. I look forward to adding them to my disclosure after today's talk, once the check clears. And I'm proud to be working with an industry that has been able to support patient need, and clearly the focus here. And again, you know, when we're talking about publicly funded healthcare, we have to remember that we're talking about a government that has not always been positive or had good clinical equipoise when it comes to cannabis. So industry is certainly not the only one with a bias. We are still living under the war on drugs that has been perpetrated by our government. So asking that same government, suggesting that the only fair research is research that's funded by a government that's been hostile to cannabis for at least 50 years is a bit rich. Also, the Doja study, more briefly, was a study of ganja yoga. So there's really nice chat about thinking about set and setting. And Dr. Baer did a really nice job of talking about the importance of set and setting. And others have noted that when clinicians sometimes prescribe cannabis, they say, go take it and do what you will. Right? We don't have really good instructions for how people ought to use cannabis. So Doja helped fund a grad student who looked at using cannabis and combining it with meditation as a way to address anxiety. And I don't think CIHR was lining up to pay for the ganja yoga study, even though I think it was a very valuable study. Unfortunately, unless you're looking at harms, it can be quite hard to get government funding. You know, I like to say that over the last 50 or so years, there's been a lottery where if you could find anything wrong, anything very wrong or harmful with cannabis, you would have a guaranteed career funded by the government, and you didn't even have to find anything. As long as you're looking hard and only looking for harms, you're good to go. So I'm glad to see an event like this that isn't solely, I mean, I really value animal research, but it's not just animal research, it's not just harm research. We're seeing the full array of cannabis research here, which is really great. I also used to work with Indigenous Bloom, no longer. All of these conflicts are more than 5 years old, so I don't technically have to report them at all. I've also been funded by SSHRC, CIHR, MyTax, and the UBC Institute for Healthy Living and Chronic Disease Prevention. So going back a ways, and there's nothing new here, so I'll go over it quickly, but I just want to point out, this was when this study came out, this was the largest study of medical cannabis users in Canada at the time. And we see the same thing we see across the board. The people are using cannabis for sleep, pain, anxiety, depression. This is not new, everybody here knows that. And these are serious conditions that affect so many Canadians, so we have to think, what are the options? Not just to look at cannabis on its own, but to think of it in context. What do people do if they're not using cannabis? They can continue to suffer with their symptoms. That's one option. If we decide that that's not a viable option, then we have to look at some of the other medicines. And, you know, it's not just my study since the time that has come out, not just our study since the time it's come out. You know, there's been this lovely meta-analysis, and I won't belabor it, but it shows that across numerous studies, pain, anxiety, and depression are widely used reasons, are widely cited reasons for use of cannabis. So we have to think, what else can we use to treat these? And you don't have to raise your hands. We know what people use to treat anxiety and sleep problems primarily. Benzodiazepines, and I'm not against benzodiazepines. There are many people, you know, front of my mind who I wish would have some benzodiazepines. But benzodiazepines are not entirely safe, right? And I'm not here to debate the safety of benzodiazepines, merely to point out that if any of this type of research were to come from cannabis, if anybody in the lottery had actually won and found that there was an association between cannabis use and Alzheimer's or cognitive decline, we would never hear the end of it. And you know, the evidence is mixed. There's some stuff that suggests that benzodiazepines might be a risk for cognitive decline, others that don't. But just to give us a little bit of context around what are some of the other options for treating this, and they also have their own harms. And of course, I don't have to belabor the harms associated with opioids. Right? We all know when it comes to pain, opioids have a lot of problems. They're a blessing to many and an important medicine, but they also have their own harms. So let's not just look at cannabis on its own. I think we want to look at cannabis in context, cannabis relative to untreated symptoms, cannabis relative to other medicines. And that's really what I want to talk about today, is the potential of cannabis to serve as a substitute for some other medicines and to reduce harms associated with some of those other medicines and perhaps non-medicinal drugs like alcohol. So that's where we're going to go today. I want to give a little bit of a brief background on the research on cannabis substitution. I'm going to update you up to 2024, maybe up to 2025, but I think just about everything I'm citing was published in 2023. I want to talk about opioid use among people who use unregulated drugs, also who I'll refer to as people who use drugs throughout the presentation. And I also want to look a little bit at alcohol and young adults. So a couple of really what we would identify as high-risk populations when it comes to the harms associated with other drug use. And then I want to talk a little bit about some of the next steps that we're engaging in. So forgive me if I move quickly. I want to just sort of provide a survey of some of the work that we've been doing in BC. Before I do that, we have to recognize some of the early pioneers in this field, and we don't have to go back that far. 2004, we see this is, to my knowledge, the first publication referring to cannabis substitution. And I also want to say that I really appreciated Dr. Baer's comments on harm reduction in the context of cannabis use. I think we should be talking about benefit maximization. The harm reduction I'm referring to is primarily the potential for cannabis to reduce the harms associated with other more dangerous drugs. But I just always like to shout out to Dr. Todd, who is a real pioneer, and we all face stigma as cannabis researchers, but I can only imagine the stigma he must have faced in 2004 and before that when he was advocating for cannabis as a way of reducing the harms associated with alcohol. So jumping forward a little bit to a point where I think was very exciting for all of us when the tides were starting to change on cannabis, and this article came out in JAMA right when we were starting the peak of the opioid overdose crisis, which hopefully seems to be breaking a little bit now, but is still a major, major cause of mortality across much of North America. And we had been arguing that perhaps cannabis could be a substitute for opioids based on the fact that people use it for pain. And then we saw this incredible result. And as many of you know, it has not held up, but I'm just trying to give some historical context. So we were seeing what we saw as an experiment in nature, where some states were legalizing medical cannabis, others weren't, and that allowed us to compare the states that didn't legalize. And what we saw, at least at this early point, was a 25% lower reduction in opioid overdose deaths. So we thought, boy, we've come up with a real solid solution for this opioid overdose drug poisoning crisis. And it wasn't just that study, of course. We also saw, using a similar methodology, that in states that had medical marijuana laws, people were using prescription drugs that might be used as a substitute for cannabis. They were using less of those, suggesting that there was substitution. And I think that's such an important point, right? If we're just piling cannabis on top of other medicines, we might still see some benefits in terms of symptom reduction and management of disease, but the real benefits come if we're perhaps replacing other drugs with cannabis. And that is what we were seeing from our survey literature. People were reporting across different diagnostic categories that they were replacing cannabis for alcohol and illicit drugs and some prescription drugs. And when we did a slightly deeper dive, looking specifically at opioids, we saw that many people were replacing both benzodiazepines and opioids with cannabis. And it wasn't just pain patients, it was also people with mental health concerns. So broad evidence for cannabis substitution, and I'm still quite convinced this is happening, but a few years later we see this follow-up of that original study that showed the dip, and we see it climbing back up. So it's not just cannabis alone. And what this suggested to me is that we need to look more specifically to understand what is the phenomenon that we're observing, right? We can't just look broadly at population. There's too many other factors coming in that are affecting opioid epidemic and the drug poisoning epidemic, that it's not just yes, no cannabis. So While the drug epidemic continued to climb, and we started to have less confidence that cannabis was the only answer, we wanted to start to look at high-risk populations, see how they're using cannabis, are they using cannabis, and in what ways might it be helpful. And in order to do this, we were able to leverage some large longitudinal studies of people who use drugs. This is the next little bit of this presentation is going to focus on data from these 3 studies through the BC Centre on Substance Use, looking at people who use injection drugs, looking at people with HIV who use drugs. Most of these people are living in the downtown east side neighborhood of Vancouver, which is an area with a lot of illicit drug use. And we also have a youth sample as well. This research was done, a lot of it by my colleague Hudson Redden and MJ Malloy at the center, who are great colleagues to work with and have done some really groundbreaking work in this area. And we see across a number of indicators some very powerful findings from people who are using cannabis. And it's not just cannabis writ large. A lot of these people are using cannabis daily. And that might be part of the why we see stronger effects here. Is it's not just yes, no, are you using cannabis? Have you used cannabis in the last month? It's are you using cannabis daily? And we found that at least daily cannabis use was associated with lower rates of initiation of injection drug using. A lot of problematic opioid use is now shifted to inhaled, but when this research was done, injection was the primary mode of administration that was leading to overdose. And so we saw that youth who were using cannabis regularly were less likely to transition into injection. We saw that people were more likely to cease injection drug use. So they're more likely to stop, less likely to start, and use less frequently. All of it associated with daily or near daily use. We also, to get back to that interaction of pain and analgesic use of cannabis, so many people who we see who are precariously housed or unhoused, or who are people who use drugs and are street involved, also have a variety of other comorbid conditions. It's not as if their substance use is the only thing that they're struggling with, and often it is chronic pain is a major driver of their substance use. And so we found that daily cannabis users had about a 50% lower odds of using illicit opioids every day. So just to summarize some of this work that we've done with the downtown east side sample and people who use drugs, we found that of nearly 1,000 people who used cannabis at least once, 40% reported daily use. So this daily use is quite common and often with therapeutic intent. So 75% reported therapeutic intention in their cannabis use. So we have to keep that in mind. These are people who are using cannabis as a medicine, who may have limited access to other medicines. And in fact, many of the medicines that they might be prescribed for their chronic pain, anxiety, mental health, PTSD are contraindicated because these are substances that they're struggling with as misuse. So when we see these people who use drugs using cannabis, they're using it primarily as a medicine, even if they don't have a medical license. And there are a number of barriers, as you can well imagine, for many of these folks accessing cannabis. There's barriers for everyone, but particularly for these folks. And as I said, we found lower rates of initiating drug use, lower frequency of injection, and higher rates of cessation of injection. No association with relapse. So we've for a long time been told that cannabis use leads to the use of other drugs. Not in this population, it doesn't. Lower rates of unregulated opioid use in daily users. And it's not just self-report. So we also have urine drug screens showing that people who have THC in their positive urine screens are less likely to have positive fentanyl screens. And without sharing too much new data, we have some very convincing new findings that are in line with all of this from some of our more recent work that has had a more granular assessment of cannabis use. And then there's the question, and this ties into what I want to talk about later, the question of treatment, right? So you are ready to make a change. Should you stop using cannabis? Is that going to interfere with your treatment? And what we found is just the opposite. In fact, that people who started OAT therapies, cannabis use was associated with better retention. And again, not just self-report, but also urine screen fentanyl. And all of this has been published, and just to see it all at once, urine drug screen at the bottom, and those are the odd ratios. You can see the odds ratios are quite substantial. Having THC in the urine is associated with lower frequency of daily opioid use, lower frequency of fentanyl, lower frequency of non-fatal overdose. And non-fatal overdose is such a big predictor of fatal overdose, and of course is highly problematic in and of itself because of the negative consequences. Often acquired brain injury, anoxic brain injury, and other aspects that make a non-fatal overdose very serious. And when we look at those terrifying statistics around the mortality associated with opioid use, often those don't take into account the non-fatal overdose that far outnumber the fatal ones. So the impact of the opioid crisis is huge. And I don't think that cannabis is by in and of itself the answer, but with a crisis of this magnitude, things that help a little bit really can have a huge meaning, huge clinical impact. So that's our work with people who use unregulated opioids. But again, I just want touching on some other research showing that it's not only those folks. This is a sample of medical users. I think they were Tilray users, Tilray patients at the time. And we see that across categories and across time, people were able to reduce their use of benzos, opioids, non-opioid pain, antidepressants across the board. So cannabis is being used as a substitute for across different populations and different substances. Just to touch on that briefly, we also know that CBD might be effective, although all the research that I'm showing, there's no reason to think that it isn't just high THC cannabis. But there's also that really great research from Dr. Hurd's lab showing that CBD, maybe in a lab setting, can impact heroin cravings. And also some work from our group showing that there may be some impact on crack use as well. And I started off talking about benzodiazepine. I just want to alert you to these studies, not from our group, also self-report, but showing that there are some pretty dramatic reductions in benzo use associated with medical cannabis use. Transitioning now to the other drug, and a different population, but also a high-risk population, is young adults. And what this study showed, a large study in JAMA Pediatrics, showed that alcohol use is going down amongst these young folks, young adults, and cannabis use is going up, but not cannabis use disorder, just cannabis use. The use of the disorder rates in the study were steady. And also the Georgia Straight, our local entertainment paper in Vancouver, claiming that Gen Z is ruining the live music business because they don't drink when they go to the club because they're eating gummies, right? Why would they drink? They're eating gummies. But this goes against a lot of the public health recommendations, which say do not combine cannabis with other high-risk behaviors such as consuming alcohol. And that's certainly something we can all agree with, stay straight or whatever, don't do anything bad. But let's take a second and think about it's not always all or nothing. So sometimes people drink a little bit. I don't want to scandalize anyone here. But sometimes people will drink a little bit and take a little bit of cannabis. And that's what's happening in nature. So that's what I think we should be examining. And I think many of us can agree that moderate use of different substances can even be beneficial. I know that looking at my parents, I would certainly never have been born if it wasn't for alcohol. So at certain types of substance use is not necessarily risky, but at a certain level, alcohol use becomes quite risky, right? So we want to know, does cannabis act like, say, cocaine and lead people to consume more alcohol? Or does it have no effect, or does it decrease consumption? And there's evidence for all of these, at least in a 2005 review. So I'm going to share some as yet unpublished data with you now, looking at some of our students at UBC, and we said only 4% said that they drank more alcohol when they used cannabis. whereas 56% reported that they drank less alcohol when using cannabis. And about 10% said they were directly using cannabis as a harm reduction so they wouldn't drink as much. And so we wanted to follow this up. This is another unpublished study, and this one used daily diary or a web app, ecological momentary assessment, however you want to describe it. And what we found, and this is just an important methodological point for some of the researchers here, is we had to ask about when they were using cannabis, because many people after a heavy binge will use cannabis and go to sleep and to wind down after an alcohol binge. So if you look at all of those data, it might appear, and this maybe explains some of the equivocal findings of whether or not cannabis increases or decreases alcohol use. If you just ask, did you use cannabis and alcohol last night, you might find that on cannabis use nights, people consume more alcohol, but we have to get at the temporal order of those things. So we broke it up, whether or not you used cannabis before or during your alcohol use or whether you used it after. And people who use cannabis after alcohol, we put together with a no cannabis use group because there's no chance for their cannabis use to mitigate their alcohol use because the cannabis wasn't on board when they started drinking. What we found is that the people who used cannabis during or before their alcohol use, they did drink slower and a lower quantity. And that could be the difference between 10 and 8 drinks, which is a big difference when it comes to the harms associated with alcohol. We know they follow that curve where after about 5 or 6 drinks, the harms go up dramatically and the benefits diminish. It was just fantastic to have the voices of patients, of cannabis users here on the stage. I think that's a great thing. I'm so grateful to Avicanna for doing that. And in so many of these cannabis conferences, we go straight from animal research to harms. So it's nice to be able to see some people who can communicate the benefits in a direct and accessible way. And I really enjoy the work. If you're interested in learning more about the opioid crisis, this book that follows a bunch of young adults on the downtown east side is really impactful. It's a heartbreaking book, but I'd recommend it I'd recommend it strongly. And also this article where she's also an author, Dr. Fast, talks about people who are using cannabis. And I just want to draw your attention to the bottom quote there. I hadn't considered going to residential treatment because I can't use weed there. And so that might be a real obstacle. We've seen all this evidence about people who are using cannabis to beneficially reduce their use of more dangerous drugs, yet it can be a real obstacle to entering treatment, which is why we were so glad to be able to start this next project, which is, and it was called the Maverick before. You couldn't get better, but it used to be a motel. It's a residential treatment facility that was called the Maverick Motel. Now it's the Maverick Supportive Recovery and Career Development Program, not inspired by the movie Top Gun. But I do feel that we are a Maverick because in this program, we're providing people with up to 2 grams of cannabis a day as part of their recovery. The cannabis was being delivered by a physician with experienced providers. And we are now looking at some of it was a pilot, so we're looking at the feasibility and acceptability. We're not looking at effects yet because we only had about 10 people through the program. But the initial reports were very positive. The participants really appreciated, and many of them, of course, had used cannabis in the past, but having the medical frame, what we saw is people asking for a lot more CBD products and using a reduced amount. I like it. The last quote, there's a limit that your brain can absorb or you're just wasting it. And, I think when we do look at some of the harms of cannabis, most of it does come from high-potency concentrates and people limiting their range of motion because they don't want to stay too far from their dab rig. So teaching people that they can get the effects of cannabis using in moderation has been really helpful. And we also got some reports from staff. There was some skepticism, as in many recovery contexts. Many folks have come through recovery themselves, and they have a very specific sense of how recovery works, and that sense often doesn't involve cannabis. But when we're able to work carefully with staff, to focus them on the medical benefits. And when they started seeing some of the positive outcomes for the people they're treating in general, we were able to get a lot better buy-in near the end of the program than we did at the beginning, and this is still ongoing. So I'm glad to report that we're going from, if you want to call it the bench, the epidemiological research, and now we're trying to put it into practice. How do we engage cannabis to help people who are struggling with substance use? As opposed to just saying, yeah, maybe it helps. How do we do that? And with that in mind, I'll just conclude by referencing a study that's going on right now, and a very tricky one to work out, but it is ongoing, where we are co-dispensing cannabis with OAT to see if it helps keep people on OAT and perhaps some other benefits as well. So thank you so much for your attention as I review some of this research, and thanks so much to the students who have helped out. And Tatiana is here, there, you can see her picture, but yeah, these are some of my other students. Don't hesitate to get in touch with me. I'm happy to chat about any of this stuff at your convenience. Thanks.
Thank you, Dr. Walsh. And fortunately enough, I grew up in Kamloops, and about 2 years ago, I visited Dr. Michael Cohen, and there were some patients from the Maverick Center, and it was amazing the stories they shared, but also seeing their life changes from being on the street to now having a job and giving back to the community to build awareness around medical cannabis. Please check out some more of Dr. Walsh's work. It's really important, especially out west where I grew up, and it's been hard hit by fentanyl, so thank you so much for your work.